Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, DrAndyRoark. Guys, I am here with the one and only Dr. Donnell Hansen. She is a Minnesota dentist, veterinary dentist. She is just what I love talking to. You will hear why as soon as you get into this episode. She is so down to earth and easy to talk to. I could just listen to her talk about dentistry all day long. She tells wonderful stories and gives great examples, and she makes me feel like dentistry is just not a big deal. Like I could just do it. And I always leave my conversations with her excited and wishing that I got to do more dentistry than I do in my current job. And so anyway, that's how I feel here. This is a great one. It's a great review of oral tumors. Oral tumors in dogs specifically we get into. Again, it's full of Donnell's patented optimism and encouragement. And yeah, we break down diagnostic process. We walk through best practices around biopsies, things like that. We talk about language to the pet owner, like how optimistic or not optimistic should we be when we find a mass in the mouth. So anyway, this is a great review, quick to the point, packed full of pearls, the way that Donnell does it, just fantastic. Anyway, let's get into this episode.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Dr. Donnell Hansen. Thank you for being here.
It's my pleasure. Thanks for having me as always.
It is my pleasure. You have been on this podcast a number of times at this point. One of your episodes is in the top 3 Cone of Shame episodes all time. It is the should I pull it, should I leave it episode. Like, hey, that's saying something. It's like 30,000 people have listened to the episode. It's a lot. That's a big, feather in your cap. I always love talking to you. We're coming into dental month, which is always puts dentistry back in the top of my mind. I wanted to bounce something off of you because I'm kicking it around and I'm kind of rolling through my brain basket. And here's what I got. So I've got a 6-month-old mixed breed dog, sort of a large kind of we call him a South Carolina yellow dog. And there's a lump between this dog's sort of teeth, right between, sort of second and third premolar. I'm looking at this. It's definitely there. Like I want to not think that there's a lump there, but it's there. It's a 6-month-old dog. And so the owners are kind of pressing me on this and they're like, well, he's 6 months old. And I'm like, yeah, I know. I thought that maybe if you don't mind, you and I could jump on real quick. And you could, I'd like you to comment on this and kind of what I'm looking at. But then 2, I was wondering if you could talk to me a little bit about oral tumors just in general. And so I have to be honest, they scare me in that they're not easy to deal with and they're hard to get to. I think a lot about oral melanoma and stuff like that. And I'm like, I know this is bad. When I look and I see something in a dog's mouth, my thought immediately is, please God, let this be gingival hyperplasia. Like that's what I think when I said fingers crossed that please let this be gingival hyperplasia. And if it's not, part of me dies. Like part of my soul just dies in that moment. I used to have a much more optimistic view of oral tumors in general. So let me stop talking here. Let me serve to you the 6-month-old dog with a lump and sort of say, let's start with that. What are your initial thoughts?
When you think about young things, so we talk about our rule outs and we talk about, you put down your list of considerations. When pets are young, most of us put cancers low on the list or tumors low on the list. And that's real. That makes perfect sense. But we know all too well, both in people and our pets, that everybody can get cancers no matter what age you are. And at a 6-month-old dog, gosh, that sounds like you said, the part of you dies. You feel a little devastated to hear about that. First, you got to rule out the easy stuff, right? I mean, sometimes we get swellings in puppies and dogs who are erupting their teeth. They can get these big sort of eruption cysts that can happen.
Yeah.
That should be done by about 6 months, unless you're a small breed dog like a Maltese or a little white thing. Yeah. Because those guys can have delayed eruptions. So if you see swellings or enlargements there, count the teeth, see where you're at. Right. But if you've got the dentition's in, you've got this, you mentioned a larger breed dog, and you don't think it's a papilloma, puppies and viral disease, you got to think about that. And of course, those are like little cauliflowers that are often white and
yeah, they're fairly distinctive, gross. Right? I mean, it's when I see it, it says papilloma to me. Like it just looks like a papilloma. It whispers.
If you're not there, if those things don't seem to fit the characteristics, then I'm always worried about there's a certain type of tumor. And again, any tumor can happen at any age, at any breed. But there's one called papillary squamous cell carcinoma that happens in our young guys. And it's, of course, I'm a dentist, oral surgeon. So we see tumors more than maybe our average family vet would do. But there's one called papillary squamous cell carcinoma that's fairly common in our young dogs. And I've seen them in old guys too. But the great news is with that one specifically, especially, it tends to be, it's not heard of to metastasize. So we won't see other body part. And gosh, if we can see it, if we can find it, so we're doing our exams, we can biopsy it, identify what it is, we can cut it out. The prognosis there is excellent.
Yeah.
Excellent. We just need to
get margins on it.
On the ball. Mm-hmm. Correct.
Okay. All right. That feels good in general. Talk to me. Let's talk a little bit more about sort of approaching these cases. So, I'm just going to be really everyone listening has to be nice to me. I'm going to be a little bit vulnerable here. I look at this and I see a lump in their mouth and I'm like, am I aspirating that? Is that what I'm doing? They're not going to let me get in there and get a good sample. And so now we're talking about, we have to do it. Like at some point you're trying to get through your day and you're seeing it and you're like, I really wish that we would just hold still for a second and I could just poke this thing, but it's not going to happen. And so I just have to take a big breath and put on my big boy pants. And I'm like, all right, we need to get into this. And so we need to sedate. If I'm going to take the time and I'm going to sedate this dog so that I can get into its mouth and actually get a sample of this, Donnell, are you okay with a fine needle aspirate? Should I be, if I'm going this far, should I be taking more of a biopsy sample? Like, walk me through some diagnostic when I'm finding an oral mass.
You're going to get some mixed messages because there are studies out there that show that aspirates can be helpful, and most of us think no. They're not going to be terrible.
Okay.
So you're right. It makes sense. You want to be as convenient, as practical, as accessible as possible. And aspirates sure feel good about that, especially when you're doing skin masses and stuff.
Sure.
But in the mouth, boy, I just have a hard time having aspirates be reflective of what I'm dealing with. And the last thing I want to do is spend their money and get that doomed non-diagnostic or inflammation report back.
Just blood. Yeah.
Mm-hmm. Yeah. I knew that. Thanks a bunch. I knew that already. Yeah. So whenever we're thinking about that, if we want to put our real big boy pants on, if tumor hits my radar screen as a possibility, it would be smart to do just a little bit of staging before we get going on biopsies.
Okay.
I get it. There's times I skip right to biopsy for costs, times, emotions, whatever it might be that inspires me to skip these steps. But if I have a choice, I'm going to think about, maybe it's smart to do chest films before we anesthetize this dog.
Okay.
In my own dog's experience, my own Ellie Mae Clampett, she had a tumor and I thought, let's just cut it out. And then my surgeon friend, he reminded me, he's like, we call him my big brother. Our big couple of us have Dr. Andrew Jackson as a big brother. And he says, Donnell, hey, you should probably take films before we do surgery on that. And right. And there was tumor everywhere.
Oh,
right.
No.
So I paused. Thankfully in the mouth, that's relatively rare. Most of our oral tumors, not all, but most really are slow to spread to other body parts. So we often have good outcomes when we take chest films, but easy thing to do, right?
Okay.
First, your labs, that's easy enough. And that's where I just have my basic screening before I do anesthesia or sedation for biopsies, if I have that option with this family.
Okay. All right. So start with some chest labs. Okay. Makes sense.
And then once we get there, if we're going to go ahead and biopsy, can take them to anesthesia, whether you do a twilight, you think about your propofol stuff. Mm-hmm. If you're going to do that, don't be taking x-rays because you don't want to ruin your film. So if you're going to take x-rays of a tumor, which is a great idea when you're doing evaluation of oral masses, make sure you have full anesthesia because you don't want to ruin your sensor.
Okay.
Practice managers, people don't like that particular
that sounds like the voice of experience is what that sounds like. That sounds like to me like someone who's seen something expensive broken.
As they say, ask me how I know, right?
Yeah. Okay, cool. Great lesson learned. Like that is a pearl I'm gonna take and hold on to. I really don't want to go and tell the manager, hey, I have to tell you something.
$10,000 lesson, right?
Yeah.
Right.
Gotcha. All right, cool.
So if we get there, then what we want to do before we touch it, it makes a lot of sense. Folks often are biopsying and they say, well, let's just remove it while we're at it. Like, because if it's removable, well, that's lovely. But with your own mast cell discussions and all other kinds of tumors, it's super tempting to lop it off because what if it is hyperplasia?
Sure.
Right?
Yes.
What if it is some of our friendlier ones like those peripheral odontogenic fibromas that we talk about, POFs, that used to be called the epulises, right? Well, then lopping it off is the treatment and that'd be really nice. But my stupid brain says, what if it's not? And then it gets lopped off, if you will. And then someone like me or you, future you, has to come back and cut out a more definitive surgery.
Yes.
You don't have to know where it was. So
that's my worry, right? Is like, what if I get in there and just, halfway it and then make it it's sometimes we intervene and it's not even that we fail to help the next person. It's that we make their job actively harder because of our involvement. And I'm okay if I try something and it doesn't work and the next person doesn't benefit from it. I really don't like to set other people back because of paths that I have chosen.
And who's ever confused right and left or 104, 204, who's ever written that wrong in the record?
Sure.
Yeah. And so when you come back to do a more definitive surgery, and you're like, oh, shoot, was this left, right? Trying to ask the family, which side do you remember it on? That doesn't work so well.
Gotcha.
So, lots of pictures is step one. And then if you have those, I'm more content with whatever you do in terms of biopsy. Just get big pieces, like big chunks. And we're talking 6-8 millimeter punches if I have that choice.
Okay.
Right? Or scalpel, that's great. Or, cut wedges. And the thing to make sure you do is, you've all gotten the report back where you take a biopsy and it's like, oh, inflammation. And your heart knows it's not inflammation.
Okay.
Right?
Yeah.
So if you can, get mucosa, tissue, and bone, which means grab that rondure and go in there and get these pieces too.
Yeah. Okay.
It helps a bunch.
All right. We need to talk about that. All right. So you touched on this a little bit. I want to clarify sort of what you were saying. So I get in there, right? Let's just say, and there's a mass that's around the size of my little fingertip, so a pea size, even maybe a little bit bigger than a pea size mass. I'm going to look at this and I'm going to say, well, I could just try to take this thing off. But then I'm worried, I go, well, I don't exactly know what it is. And I don't know if I'm going to leaving pieces of it or things like that. Would you encourage me to say, Andy, don't try to take it off. Just get a big piece of it and let's find out what it is. Because that way, if it is something, then you'll be able to find it easily. We can go back. Or would you say, Andy, go ahead and take it off and just document where it is, get good photos and things like that. So if we have to go back, it's easier to go back. So how would you weigh in on that?
Yeah. There's an adage amongst the veterinary dentists that say, ask 10 dentists, get 10 answers.
Yeah. Okay.
So my friends might say other things. Here's where I have discussions with the family. And I really believe that disappointment is just expectations missed.
Yes.
So if I can take a moment before I do all this, not under anesthesia, it is not the time that I spend time talking to families about this. But if I know about it beforehand, I will say, here's our benefits and risks. If it's one of those smooth, pink, from the gingiva, right from the gum line, kind of growths that look like a blueberry or half a blueberry, and I've taken photos and I know where it was and I've make my measurements, I can be convinced to say, Andy, just take it off. Like a gingivectomy, take it off. As long as I've explained to the family, hey, listen, I'm going to submit this. And if this comes back more concerning, that's not the solution. We have more surgery to do. But if it comes back as hyperplasia or again, maybe that POF, those guys can be a little friendlier and we can behave differently. Well, then we'll just watch it and see what happens. And then success. The one procedure was the trick. But dear family, if it's something more concerning, hey, budget plan, emotionally plan for surgery again in the future.
Yeah, I like that.
If they're not game to be flexible with me, then I'm more by the book. I just take a sample of it rather than cut it off. But my practical self wants to cut it off sometimes too.
But that I love that. That is a wonderful approach. That totally makes sense to me. Jumping back into this, say I get into it and I say, okay, I'm gonna do this by the book. I'm gonna take this biopsy. I'm gonna sort of take some samples. I want to make sure that I try to get even some bone sample as we talked about. Talk to me a little bit about pain management control, things like that. This is gonna hurt. I've taken the dog. I've done the chest rads. I put this dog on anesthesia. I'm in there and I'm getting it. Do you have, so just talk to me about general pain control philosophy for something like this. To me, I go, ooh, that seems terrible. Yeah. What does your pain control setup look like when you go to do these?
Right. So just like you would do for any other surgery, we've pre-meted them if we're going to do the anesthesia. So there's pain control there, right? There's obviously pain control in the gas coming through the machine. There's pain control there. If my tumor is not in the area of my nerve block, my regional anesthesia, I'm willing to block these. Sometimes there's a mass in the way of my block and I don't want to stick needles where I don't belong and drag things places. So if there's a large enough mass that's blocking our access to a good regional anesthesia, well then I'm not using that resource.
Okay.
Instead, if it's these soft tissue things, in my secret brain, I think this is no different than when you get a mole removed. And I don't go home with codeine after I get a mole removed, right?
Yeah.
So maybe some anti-inflammatories, or maybe it's the tumor itself, the mass itself is painful. So anti-inflammatories, If you're a gabapentin person, all those things are things we can use to go home, either for our biopsy purposes or because it's a tumor and those hurt in the first place sometimes, just to help with that too.
When you are talking to the pet owners and you're saying, so all this is coming together into a nice little package, which I love. So I'm talking to the pet owners and I'm sort of setting those expectations and I'm talking about the approach that we're going to take and I'm saying, I don't really know what this is, but we're going to go in and find out and things like that. And they're looking at me and they're saying, well, Dr. Roark, this sounds bad. It's cancer, right? Is this cancer? This is bad. Donnell, how do you frame that up so that you are honest with them? Like, how optimistic are you? What kind of communication do you give to them before you really know what you're looking at?
Yeah. So I really believe my one job is to build trust. Mm-hmm. Like we all have the jobs that we do, right? But the one job that I actually have is to build trust. And so, and I'm not the same as a family practitioner who they know them, right? And they've built trust over time. I have to do it in these 12 minutes or in my case, 30 minutes, which my team just loves. They love that I spend so much time. That was sarcasm if you didn't catch it. So here's what I say to families, and right or wrong, you can come at me with questions or with critiques, but I really do sort of lay it out there and say, hey, you guys, I know it's hard to come see me when there's this concern of a mass. Mm-hmm. I'm sorry you have to meet with me in the first place. Mm-hmm. I say, I know it sounds super scary. And the word cancer, many families never even make it to me. They heard cancer and they don't even come to the door, right? But listen, I know it's scary. There's lots of steps to take here. I do let them know that there's no right and wrong. Like we can go down the long road. We can go down the short road. All the options exist in front of us. And I'm not here to judge about that. Mm-hmm. So let's walk through it. Are you up for that? And they say, sure, of course, I'm up for that. It's okay. We'll walk through it and start moving forward. And then I do make sure I say, it's important for me to say to you that many masses are treatable, right? And if some of the things I'm going to say sound a little scary, but pause. We'll come back around. I'll bring it back around and we'll decide what feels right for you and your family and your pet. The reality, the cool thing is if you can acknowledge the worry, and I'm sure you obviously know this already, and help guide them through it, I am astounded at how much compliance we get with getting to move forward on surgeries that people come in saying, they say the first thing out of their mouth, I'm not cutting bone out.
Yeah.
I'm not doing that to him. Get it? Baby steps. And many families take us up on it.
That sounds good. No, I really appreciate that. Donnell, thank you so much for talking through this with me. Tell me more about the four-legged tooth fairy. Four-legged tooth fairy is a CE syndrome. You can probably see it in the background here. You know, early in my career, folks would ask us to come out and teach at their places, and we would do that. And we still sort of do that sometimes now. But it felt like maybe folks needed more than 4 hours of us blabbering in their spaces. So we built this space so vets can come hang out with us for, this case is 3 days. We start tomorrow for this month's. It's -20 here today. Oh, wow.
-20. People are coming from all over. So I feel some sort of grief for them.
Yeah. Boy, they're invested. They're for me to come to where you are when it's -20 is I would have to really want this.
Yes. We had a veterinarian from Alabama come last January and the snow was above her head. So she took pictures with her mittens that we gave her because she needed mittens. Everyone needs mittens.
She gave her mittens.
We spent a few days talking about teeth and just kind of getting back to confidence. That's our goal. It's confidence.
That's great. Confidence. Where can people learn more about this if they were like, I would like to participate in something like that? Maybe when it's not -20, but at some point in the future. Yeah. Where would they find you?
Webpage, fourleggedtoothfairy.com.
I'll put a link in the show notes. All right, great. Donnell, thanks so much for being here. Guys, thanks for tuning in and listening, everybody. Take care of yourselves, gang. I'll talk to you later.
My pleasure, guys. See ya.
And that's what I got. Guys, I hope you enjoyed it. I hope you got something out of it. Thanks to Dr. Donnell Hansen for being here. Thanks to you for being here. I hope this makes you feel more relaxed and comfortable and excited to do some dentistry. Gang, take care of yourselves. I'll talk to you later on.